Right, good afternoon everyone. Seats code is on the board, I'll put it up again later. So this week we had tutorial 1. The sketch solutions are now available on Blackboard if you want to have a look at those, and some videos from 2021 as well. Tutorial 2 will happen in week 7, and that will cover the material that we'll go through today and next week. The tutorial 2 questions are already online if you want to have a look at them, but obviously there's no need to do that until the end of next week when we've gone through the material in topic 3. And that's the National Student Survey link again. So today we're going to look at the production of healthcare. And what I propose we do today, because it's a relatively short lecture, because we used to have like some reading in the class but it didn't particularly work well, so we'll finish a bit earlier, then you get some time to do that reading in your own time. So essentially what I want to look at is the production of healthcare, and the whole point of this topic is geared to the idea of how should we produce healthcare. Should we do it in lots of smaller hospitals, or should we do it in these super hospitals that can possibly benefit from concepts such as economies of scale and economies of scope? And we'll go through all of the implications of that today. But obviously a very topical conversation. There's lots of debate in white papers in the government at the moment across the world, not just in the UK, about the optimal way to produce healthcare and how to deliver healthcare. So do we want super hospitals or do we want lots of smaller institutions? And some of the topics we'll go through will help us sort of gear up towards answering that question. That's just an overview of what we'll do. And again, a lot of this is grounded in microeconomic theory, but the way we produce health and healthcare is again slightly different. We have this idea of multi-product firms. So hospitals, GPs, nurses don't really produce one type of healthcare, they produce lots of different things that are all badged under the umbrella of healthcare. And again, the key things that we want to really think about is this idea of returns to scale, super additivity, and these fixed factors, and how that relates to costs, and the idea of can we bundle these things together to produce the same output for a cheaper cost, or can we produce more output for a fixed cost, depending on whether we do it separately or together. And then we'll finish on scale and scope economies, which essentially are terms that bring those factors together. Just very quickly in topic 2, we looked at the demand for health. So why individuals want health care, what other factors affect their health other than healthcare, and how these bundles behave together, and how is health an element of the utility function. And essentially that all come together under this model called the Grossman model, which brings together health as a consumer good and producer good that individuals want because it gives them happiness or utility, but they can't buy it, so they have to go out and produce it themselves using things that they can produce on the can buy on the open market, but in combination with their time and effort. And again, the main thing we're interested in was the graphical representation, but we did very quickly touch on the algebraic stuff as well. And then the models are very simplified, but it does allow us to make some predictions on how people and groups of people might respond in the presence of government intervention. So what would happen to people's health, their demand for health care, if things change, such as income, education, prices of goods, etc. Then we touched on how well a model does in the real world, paying particular attention to education. It's a bit mixed, but it's pretty good in terms of its prediction. So remember, the main prediction is that education increases people's efficiency of producing health, given a fixed set of health inputs. And the majority of evidence would tend to back up that hypothesis, but it's not universally true. There are some studies that find no effect of education on health. And again, a lot of the things we talked about were grounded in uncertainty. So uncertainty is obviously ubiquitous. It's not specific to health. Uncertainty affects almost everything we do. But in health, the uncertainty is probably more prominent. And again, there's much more likelihood of there being asymmetrical information when we think about health than other goods and services. So essentially that was the demand side. Today we'll flip that and look at the supply side. So basically the other side of the coin, if you like. So today we'll think about how healthcare is produced, and then next week we'll talk about how healthcare is supplied. So think about it logically, you have to produce something before you can supply it. So we'll go through that process. And again, a lot of this is quite standard, but there are some subtle differences between healthcare that you can hopefully relate to as we go along. So the production of healthcare from a health economics viewpoint allows us to apply economic models, economic theories, to the decisions that individuals, firms, governments make about supply of healthcare. But again, we've got these special properties. So just a recap, supply theory allows us as economists to analyse the behaviour of various economic agents and how they behave in that economic environment. Obviously the economic environment is quite important, and in later topics you'll think about healthcare being provided in different settings. So in the UK, for example, it is provided through primarily a taxation funded system. That could lead to different production decisions if it is funded in a private insurance system versus a social insurance system. But on the whole, the same general principles apply, but there are subtle differences based on the economic environment in which these firms operate. Now, we're going to talk about the production of healthcare quite generally, but actually there's lots of different sub-markets, there's lots of different productions, there's lots of different elements of healthcare out there. So for example, a pharmaceutical company is going to operate very differently to a GP or a family doctor. So a pharmaceutical company operates in a private market, and that private market has many different characteristics to, for example, a public sector market in which GPs, family doctors, find themselves operating in. So those conditions, those constraints really affect the decisions that people make, firms make about the production and supply of the various elements of healthcare. As we've said, to be able to supply something, you need to first produce it, and that amount of production, how much we can produce, is going to differ based on the circumstances in which we find ourselves operating. Obviously, costs are one element of circumstance, but they're not everything. There are things like regulation as well to bear in mind. So cost is probably the main thing to think about, but there are other non-cost factors that influence the environment under which firms or producers of healthcare operate. We're going to apply some quite standard terminology. So the stuff that is produced, the goods or services, the healthcare that is produced, is the product. And again, that could be very, very wide reaching. So it could be a medical procedure, it could be a drug, a pharmaceutical intervention, it could be a doctor supplying their time, for example. It could be counselling, it could be lots of different elements of health and care. And obviously they're all very, very different, but we're going to think of healthcare quite broadly to start with, and then we'll think about specific examples as we go along. And then firms produce the products, and obviously here firms can be, again, quite heterogeneous. So a hospital could be a firm. A hospital produces many different types of healthcare. It could be a general practice or a family doctor, and again that produces quite different types of care. And in many models we have this what's called a gatekeeping model. So to enable to get a hospital appointment, you first need to go to your general practice. So the production of services in general practice influences the production of services in hospitals in many, many countries. And a drugs company is also a firm, but they're going to behave very, very differently. They're less regulated. They have much more emphasis on maximising profit, for example, than a hospital might. So again, you've got lots of different firms operating in similar but quite distinct sectors. And then the output is simply the amount of stuff, the amount of healthcare that is produced by the firm. But how we think about defining output when we think about health and healthcare it's not as straightforward as counting stuff, because the stuff we need to count isn't obvious. So there's essentially two almost diametrically opposing views. So the first is that the outputs of healthcare is essentially health. All we're interested in when we think about the production of healthcare is how many units of health that produces. But obviously, because of uncertainty, it's hard to be sure that the products of healthcare are actually leading to the changes in the health. There could be many other factors that lead to population changes in health, for example. If you simply look at measures of population health as a measure for the output of healthcare, it gets quite complicated. And then if you do use health as the ultimate output of healthcare, how do you think about markets? Because we've said you can't trade health per se. So if we use health as a measure of the output of healthcare, there's lots of economic theories that simply don't work, because you've got these problems about uncertainty and non-tradability of the ultimate output. Other people argue that only people can produce health, so I think back to the Grossman model where healthcare is one input, but actually it's the person that produces that health. So healthcare is what we would call an intermediate output, and then you can count those intermediate outputs, and that's things like how many procedures are performed, how many operations are performed, how many drugs are made, how many sessions of counselling are offered, how many patients does a GP see. Those are countable things, and actually they could be argued to be the outputs of that production procedure. But then people in the first camp have said, yeah, that's all very well and good, but so what? The main point of this healthcare isn't just to produce these things for the sake of it. The only value in producing healthcare is to improve people's health. And if you're not accounting for that change in people's health, there is no certainty that producing more healthcare is good. And in the extreme, people argue that not all healthcare procedures are good, so that it doesn't necessarily need to be monotonically true that more healthcare production leads to the ultimate aim of better health. Obviously, on average and at the aggregate level, you'd think that would be sort of true, but some people are so opposed to counting healthcare procedures that they argue that it could be harmful to people to continue to produce certain procedures when they're not needed. So it's a really interesting debate about how we think about output in healthcare. We'll sort of abstract away from it a little bit here, and we'll consider either of these to be valid measures. We'll probably focus mainly on the second one, because that's easier to count. It's a lot easier to see how many procedures are produced than it is to measure measures of population health. And we'll keep coming back to this idea that many, in fact all, producers of healthcare are multi-product firms. So many hospitals are going to produce, well, all hospitals are going to produce lots of different elements of healthcare output. So that would link back to us favouring the first argument, but for practical ease we'll concentrate mostly on the second one. And then just a very, very quick recap into production function. So a production function essentially summarises the relationship between how much stuff we put in and how much stuff we get out. So it's a graphical or algebraic representation of the relationship between inputs and outputs. And it basically describes how output changes as inputs change. And we typically tend to think of inputs in three broad forms. So there's labour, there's raw materials, and there's capital. And actually we're probably going to ignore raw materials and focus for ease on labour and capital. But essentially a production function shows us how output changes as you change inputs. So for example, a question in specific to health might be how many doctors and nurses are needed to produce a knee operation. And can you substitute between doctors and nurses? And this is very, very policy relevant at the moment. So there's a whole ongoing, quite lively debate about the skill mix. So how many doctors versus non-doctors you have, particularly in primary care. And can you use something called physician associates, which are less intensively medically trained people who work in general practice? Can you substitute fully trained doctors to physician associates, and does that lead to better or worse health outcomes? So again, this is a very simple topic, but it is used quite a lot by the government, the NHS, Department of Health and Social Care, to make decisions about how the optimal mix of staff will be employed in primary and secondary care. Essentially, so the production function is used to quantify, as I said, output change given input changes. And essentially, it's all about this idea of efficiency in the production process. So at a very high level, we've got some level of output Q, which is some function of all of the inputs x1 through xn. Then we have these terms for scale economies, which we'll come back onto, and then efficiency. So we need to account for these two factors as well as the level of inputs. Then, obviously, as we've said, economists are interested at the margin. So what happens to output as you change input by 1 unit? And essentially that is the marginal product. So marginal product of an input is a change in output resulting from increasing that particular input by 1 unit, but holding everything else constant. So going back to our operation, how many more knee operations can we perform with 1 extra surgeon, holding everything else constant? So now a very simplified example where we've got output as a function of capital K and labour L, then essentially the marginal product of capital, so how many more things can we do if capital increases by 1 unit, is essentially the ratio of the change in output divided by the ratio of the change in capital, holding labour constant. And then algebraically, if we've got a well-behaved function, that's essentially the partial derivative of the production process. And then you'll probably be all aware that the marginal product varies with inputs. So the marginal product of going from 1 to 2 is very different from the marginal product of going from 100 to 101 doctors, for example. And that's essentially called the law of diminishing marginal return. So going from 1 to 2 doctors is going to lead to a bigger change in output than going from 100 to 101. So we can show this graphically, and that is done using something called an isoquant, which is a graphical representation of the production function. So we can plot in 2 dimensions if we have capital and labour. That's why it's useful to only have 2 broad inputs, because we can work in 2-dimensional space. And essentially an isoquant shows us how we can trade off between capital and labour to produce a given amount of output. So it's quite similar to an indifference curve, but there's one quite important difference. So theoretically, an indifference curve shows us the utility that is actually gained when we consume certain levels of x1 and x2, whereas an isoquant is the maximum, the theoretical maximum possible output when we've got ideal conditions of inputs, x1 and x2, for example. Now, if we have something called technical efficiency and we do produce at maximum efficiency, then they are perfectly the same. So the maximum possible is exactly what is achieved. And an isoquant essentially assumes that firms are technically efficient. That means they can operate on the isoquant. The flip logic of that is that if a firm does manage to achieve technical efficiency, then it can't produce more output without using at least one more input. So again, they're quite similar to indifference curves, but we do have this sort of technical efficiency thing that we need to bear in mind. So we need firms to be operating at maximal efficiency such that they're on the frontier. So you'll have all seen these before. So this is an isoquant, so it shows us how operations are produced using number of nurses and number of doctors. And essentially the isoquant is this blue line here. So it shows us the amount of doctors and nurses that are needed to produce 1,000 operations. So we can look at inefficiency. So if a hospital is at point A, then that's inefficient. It is using more doctors and nurses than it needs to produce 1,000 operations. And essentially we can work out how inefficient that hospital is. So essentially we just take a line from that point to the origin, so OA, and then we basically look at the ratio of that distance of that line to the line from the origin to the point on the isoquant, and that's something called the Farrell radial measure. That can allow us to see how inefficient hospitals are relative to this technically efficient isoquant. And again, so this we can work out the marginal rate of substitution, so we can see how hospitals can increase the number of doctors by substituting away from the number of nurses. And again, the marginal rate of substitution is going to differ as we move along the isoquant. So that's essentially what we've just said. The marginal rate of technical substitution is the slope of the isoquant, which varies at various points on the isoquant. And that allows us to trade one input for another input. And it allows us to work out how many nurses we're going to have to give up to get one more doctor, how fewer doctors we need to have to get more nurses, etc. And again, it gets smaller the further along the line we go, and it's linked to again, but not exactly the same as the diminishing marginal returns we saw in the indifference curve space. So producer theory and consumer theory are very, very similar, but there are subtle differences that we do need to account for. So again, this is very, very basic stuff. But it is used, and it is used in various different contexts. I've said an example that is being used as we speak is looking at skill mix and how general practices can trade off doctors against not quite doctors, so physician associates, to get the same amount of procedure. I don't know whether you've seen this in the news, but it's incredibly controversial. The British Medical Association aren't happy at all. They're saying that trained doctors are being substituted for non-trained people, and they are threatening all sorts of action based on this. And again, the people in the Department of Health and Social Care are using this sort of marginal rate of technical substitution to back up their argument with little success, to be honest. But another example, so a study in the early 2000s looked at production of health in Thailand, and here the output was the number of live births per 1,000 population. Essentially, they're trying to get the optimal ratio of staff in maternity services such that they could get the best possible outcomes for mothers who are expecting. So they looked at inputs in labour and capital, and in labour they had doctors, nurses and pharmacists, and in capital they had measures of the number of available maternity beds. What the study wanted to do was look at the marginal rate of technical substitution over time. So they included time effects, so they had a longitudinal study, so they observed the same hospital in the same regions over a long period of time. They're interested in regional heterogeneity to see whether certain regions, certain hospitals were more efficient than others. And they also had controls for the number of alternative medical practices within the region in case people wanted to substitute away from the former maternity services. The results were quite interesting. They found there was a positive marginal product for nurses and number of beds. So the more beds you had, the more procedures you could produce. The more nurses you had, the more successful procedures you could produce. But interestingly, found negative marginal products for doctors and for pharmacists. So essentially, the more doctors you employed, the worse the health outcomes became. Now that's obviously far from intuitive, but they basically looked at nonlinearities as an optimal measure of the number of doctors. Any doctor above the optimal measure led to something called a crowding out effect. So essentially, too many doctors just got in each other's way and led to an adverse health event. So although it's negative, you can get an expected result when you include sort of a quadratic term, such that it does increase, but then it reaches a theoretical maximum level. This was used to plan the workforce in Thailand. So again, very, very, very simple economics. But it has been used to allocate resources between regions within Thailand. And essentially, they plotted the isoquants, and they were the correct theoretical shape. I mean, you can't really see it in this diagram, but this is the elasticities. So they are all negative, the marginal rate of substitution, how things are changing between inputs. And essentially, we get what we'd expect. But what is interesting is there's a lot of variation between regions, and there's a lot of variation over time. So hospitals are very good at adapting. Once they realise they're doing things not quite well, they can work out what they aren't doing well and change. So essentially everything is regressing towards what we'd expect it to be, this sort of level, this pink line here. Okay, so very, very simple economics, but it is used to try and understand how we can best allocate resources between nurses, doctors, beds, etc. So the isoquant is fine, but again it assumes everything is technically efficient, and that's a very strong assumption to make. So instead of assuming we're operating at a theoretical maximum, we can just look at real data, and we can use real data to construct something called the production frontier. So essentially, if we can get information from every hospital about how many doctors, how many nurses and how many operations they produce, we can then plot all of these points on a diagram, and we can look at the real world. And essentially we can use this real world data to construct a boundary. So essentially the closest points to the origin, we're going to assume, given that they are producing the same amount but using fewer resources, they are more efficient than hospitals who are producing the same amount but maybe further away from the origin. So it's not quite technical efficiency, but it's our best guess at efficiency within the system. So again, this production frontier is sometimes called the best observable performance or the best guess at efficiency within a sector or an industry. So here, for example, is a hypothetical example. So all of these hospitals might have produced different levels of outputs, but you can standardise it to produce the same amount of output. So essentially we can see how many doctors, how many nurses each hospital employs, standardise it such that they all produce the same amount of operations. Then essentially all of these points that are closest to the origin are this frontier. So this is our best guess of what efficiency looks like in the real world. So it might not be technical efficiency, but it's as close as we can get within a particular system or region or country. And again, we can apply this Farrell radial measure to see how inefficient hospital A is. So essentially hospital A could reduce both nurses and doctors to go from A to B, and we can get an estimate of how inefficient this hospital is by looking at the ratio of the line OA to OB. So this is used a little bit, because essentially we can do this. We can count numbers of doctors and nurses, we can count procedures produced, we can normalise such that they're all on the same common currency, and we can get an idea of how inefficient various hospitals are. Obviously there's a lot of very strong assumptions underpinning this. So it assumes that all hospitals face the same environments. If some unobserved factors, or even observed factors that we don't account for, are explaining why hospitals are inefficient and we're missing some important variations. So for example, it might just be more expensive to employ doctors and nurses in certain areas. That might be why they can afford fewer doctors and nurses. Or it might be that the population is inherently sicker. So even though you're producing 1,000 operations, the 1,000 operations in hospital A might be much more complicated than the 1,000 operations in hospital B. So again, econometrically we can account for this. We can adjust for the population structure of the hospital's catchment area. We can remove some of these factors, but there will always be the problem that there is some residual confounding that we simply can't model away. But this is the best guess of what technical efficiency looks like given real data. So all we've talked about so far is assuming that hospitals or whoever the firm is in the healthcare sector is only producing one good. So an example we talked about before, it was just knee operations. But obviously, hospitals produce many different types of healthcare, different types of output. So what we call these is multi-product firms. But we need to think carefully about how we analyse the output of multi-product firms. So if we analyse each production function separately, then we're going to ignore three really important economic issues. There's going to be a lot of shared inputs. So inputs that are used to produce one thing can be very much used to produce another thing. So for example, in a hospital, basic, for want of a better word, nursing can be used to produce many different types of healthcare. We also need to think about how many inputs to use, but also how many of each of the outputs should be produced. So what is the ratio of outputs we want? Do we want to produce the same amount of every type of healthcare? Or do we want to produce more types of healthcare than others? And how do we make that distinction? And again, managers, chief executives, people who oversee hospitals are shared between all of the different outputs. So one is sort of bottom up, it's the staff producing it, and three is the top level people who are making the decisions. But they are both shared by each of the elements, each of the healthcare products that are produced in the same hospital. The production function for a multi-product firm, again we're just going to focus on two for simplicity because we can draw it in 2 dimensions. And essentially what we're interested in is something called the product transformation curve, or the production possibilities curve, which links back a little bit to the graphical representation of the Grossman model where things are being produced. So in that case it was health and other consumption. Here it's 2 different outputs, 1 and 2. Then essentially the slope of that production possibilities curve, or the product transformation curve, tells us how we can substitute between the 2 different types of outputs. And again, a product transformation curve is the theoretical maximum, assuming technical efficiency, but we can, if we want, get real world data and look at something called the production frontier. So that's what these 2 look like. On the left hand side is the theoretical maximum, assuming technical efficiency, which again you'll see is very similar to the production possibilities curve in the northeast quadrant of the Grossman model. And then if we use real data, we can get information on lots of different hospitals, see how many outpatient appointments they're producing, so how many inpatient appointments they're producing. And we can plot them. If we normalise the inputs they're using to produce them, we can assume, for example, hospital at point B is more efficient than a hospital at point A. Because given a fixed amount of inputs, it's producing both more outpatient appointments and more inpatient appointments. And again, we can look at the degree of inefficiency by looking at the ratio of the line OA to OB. So this is quite a simple concept, but again it is used quite a lot to try and understand how hospitals can use their resources to produce a different type of output given a fixed set of inputs. So how much one type of procedure they have to sacrifice to allow them to produce more of a different type of procedure. So again, algebraically, the slope of the production transformation curve is the rate of product transformation. So it shows us how we can transfer between one output and another. And essentially, we get the same result for when we consider the very basic two-dimensional case as we would if we considered many different outputs. So essentially, it's simply the change in output 1 divided by the change in output 2. And that generalizes to many different types of output. So now we'll talk about something that is very topical, and again, people ask this question quite a lot. So people often ask, if we employ twice as many doctors and twice as many nurses, what's going to happen to the number of operations we can produce? So we've seen we've got big waiting lists in many countries at the moment. So people say just employ more staff. Obviously that itself has got issues because, as we said in topic 1, the supply of healthcare staff is quite sticky. You can't alter the number of doctors on the market in the short term. But assuming you could, if you doubled everything, so you increase the number of doctors by 100%, you increase the number of nurses by 100%, increase the number of hospital beds by 100%, would you get twice as many operations as you would at the moment? And essentially, intuitively, the answer should be yes, but that's not always the case. In fact, it's very rarely the case. And this is essentially a question relating to returns to scale. How does output vary as inputs vary? So the returns to scale essentially shows how output change as we change all of the inputs by the same scale factor. And then if we just think about doubling everything, so if we doubled all of the inputs and we got exactly a doubling of the output, that's constant returns to scale. So everything in the input group has doubled, we've got a doubling of output, so that's constant. You've basically not changed the relationship between outputs and inputs. However, if by doubling all of your inputs you get more than double output, that's something called increasing returns to scale. The relationship between outputs and inputs has increased. You've got more than double, even though you've only doubled inputs. However, if you double all inputs but you get less than double output, that's decreasing returns to scale. The relationship between inputs and outputs has got weaker. Essentially, you can show this algebraically using Cobb-Douglas functions. I'm sure you've all seen this type of thing before. And essentially, in this very simplified Cobb-Douglas case, the sum of the powers tells us whether it's increasing constant or decreasing returns to scale. So again, we can show this graphically. So we've got an isoquant curve Q1, which is 100 operations. If we double both of our inputs from 20 to 40 and 17 to 34, we can move to isoquant Q2. Essentially, if Q2 is 200, then we've got constant returns to scale. If Q2 is more than 200, we have increasing returns to scale. But if Q2 is less than 200, then we have decreasing returns to scale. And again, this is quite important because people tend to use this very simple economic concept to argue that healthcare providers, hospitals, for example, should be very large. Now, they make 4 broad types of arguments that each seem sort of sensible, but you can very quickly pick holes in each of these. So first, people argue that large organisations can specialise much more easily than smaller institutions. So bigger hospitals are more likely to be able to recruit specialist surgeons, so they can do more types of healthcare than, for example, smaller hospitals can do. People argue there's technical and managerial indivisibility. So big machinery, for example, big machinery can do lots of different types of things that are consistent and can be applied to different types of treatment. So smaller hospitals are unlikely to be able to afford these big machines, whereas big hospitals are, and they can get the value out of them because they're always going to be used by many different patients who are always there. There's an argument that inputs may not increase proportionally. So if you have a big hospital, it's got more resources to invest in things. Big hospitals have more ability to do things like healthy living campaigns, so you can get these more than proportional increases in bigger facilities. And the last point is this sort of more statistical point. The hospitals need to be able to predict who's going to come through their door at certain days. And essentially what hospitals do is they use historical values of use of services to model what's going to happen in the future. So for example, they'll know the day of the week, the month of the year, the seasonality, the time of day, etc. So essentially using historical values, they will predict who's going to present at their hospital at each hour of each day of each month. Now statistically, these predictions get much better the bigger the sample size. This phenomenon called the law of large numbers. That means basically the estimates get much closer to the true value the bigger the sample size. So if your hospital is bigger, you're getting more patients through the door, you're much more likely to be able to accurately predict who is going to present at your hospital than you are for a smaller hospital with bigger fluctuations in demand. However, people have argued that there are likely to be factors that could lead to decrease in returns to scale. So if you do have super hospitals, you might get managerial inefficiency. So if you've got one manager managing one super hospital, it's much more likely they're going to be overworked than lots of different managers managing smaller hospitals. And in the real world, people always argue, yeah, this is all very well, it's a theoretical concept, but you just can't increase capacity. But obviously, in a purely theoretical sense, we assume you can do that. But in the real world, that's not possible. You can't simply double the size of your hospital overnight. And then we've said hospitals are multi-product firms, and this concept of returns to scale are much more complicated when we've got different levels of, we've got different outputs to think about. So if you doubled all of the inputs, but that could then lead to different proportional changes in different outputs. For example, if you doubled all inputs and you doubled output Q1, but you only increased output Q2 by 50%, is that increasing or decreasing returns to scale? So for Q1 it's constant, but for Q2 it's decreasing, so overall we're not sure whether that is a good thing or a bad thing. So there's lots of theoretical arguments why returns to scale are an appealing concept to use to justify large hospitals, but actually in the real world they don't stand up to much scrutiny. Obviously we work in the land of fixed factors, so returns to scale are all long run phenomena. So we've got this idea that you can change all factors of production. When you can change all factors of production, that is what economists call the long run, and we can basically do what we want. But that's just not the case. So we do have some constraints. We're much more likely to operate in the short term, where at least one, but most likely some, factors are fixed. So as I've said, you can't just increase a hospital bed size from 100 to 200. It just doesn't happen instantaneously. That needs to be a very long process. It doesn't happen instantaneously. And if you have at least one fixed factor, by definition you're going to have diminishing returns. So if something is fixed, you cannot get increasing returns to scale. And again, if you want to see this graphically, there's a nice representation in the Morris book. But people tend to use increasing returns to scale as a justification for large hospitals, but they ignore this phenomena that actually we just don't live in the long run. We live in a world of constraint and scarcity, so we can't change all factors instantaneously. But we can look at short-term equivalents to returns to scale, and that's something called additivity. So we're going to look at additivity in the production function first, and we'll return to additivity in the cost function later on. So there are reasons other than returns to scale which are used to say that bigger hospitals should be better. So essentially, people argue that bigger hospitals offer a number of different properties, so they're more convenient to patients. So at the moment there is this phenomena of something called multimorbidity, and that essentially says many people have more than one health condition. So if you had a lot of smaller specialist hospitals, patients would have to visit each of those hospitals for each of their conditions. However, if you bring everything together in one super hospital, then the same patient can just get everything done within the same facility. So that is more convenient in theory. However, you can make a counter argument that if you happen to live closer to a hospital that was shut down and move to a super hospital, that is very much inconvenient to you. So there's always a flip side to all of these arguments. But the main economic argument is that people suggest that you can produce more healthcare for a given or a fixed set of inputs. And now we're very much in the short term. We're not changing inputs at all. We're assuming everything is fixed. But we want to see if we can agglomerate all of these into a big super facility, can we produce more with that same fixed amount of input? So people argue that many factors can be used for different healthcare outputs, and they're not always used if you only produce certain types of healthcare. So as we said earlier, an MRI machine can be used for many, many different types of health condition. It can get images and scans of various parts of your body. It's not specific to any given part of the body. But if you had, for example, condition-specific hospitals, the MRI machine will not always be in use. But if you've got a big facility, then it's much more likely to be used, so you're getting more efficiency from that fixed investment. Same for general nursing, for support staff and operating theatres. They can be used to treat almost any type of health condition. If you have big facilities treating many different types of conditions, there's always going to be some demand on each of these products. Whereas if you have smaller hospitals that only specialise in certain conditions, you might not have demand of them all the time. So essentially this is called additivity of production, or additivity of the production function. And the key thing that we're interested in is this notion of superadditivity of production. Superadditivity of production arises when it's possible to produce more healthcare given a fixed set of inputs. Now that's the key thing, given a fixed set of inputs. So essentially if we've got a fixed set of inputs and we can produce more using that fixed set of inputs, doing it one way than another, then that's called superadditivity. So for example, if you think of a dentist, so if you have a dentist who can provide one filling or one scaling in 15 minutes, then essentially you have this red line here. So they can either produce 4 fillings, or they can produce 4 scalings, or 3 of 1, 2 of 2, and 1 and 3. But a general dental practitioner or a general dental facility can produce both fillings and scalings. Then, for example, the X-ray machine, the support staff can be used interchangeably between patients who are getting each of these things done. So you could, for the same dentist and dental nurse, get this amount of output here. So this blue line is called the joint production frontier, and essentially because it's further away from the origin, we can produce more using the dentist and the dental nurse in one shared facility than we could if it was done separately. So we've got superadditivity. Now it is possible, of course, you can have subadditivity, so if people get in each other's way and you try and get everything into the shared facility and it's too crowded. It's not impossible to imagine scenarios where everyone in one place would lead to worse levels of output than if you produce them separately. But typically, this idea of superadditivity that is used to argue why we need to invest in super hospitals. So then we've got costs, all very standard, and we're going to argue that if you can produce the same amount of output for cheaper in one facility, then you've got subadditivity of costs, and that's a good thing. But before we do that, let's just remind ourselves what costs are. So essentially, the total cost of producing something is the unit cost of the input times by how many of those inputs you use. So if we use n inputs x1 through xn, each has price p1 through pn, then the total cost is essentially the sum of the price times by how much of the input we use. The graphical representation of a cost function is called the ISA-cost curve. So this is very similar, if not identical, to the budget constraint. And essentially the slope of the ISA-cost line is basically the ratio of the two prices. And again, we get this relationship similar to consumer theory, that if you have a production function and an ISA-cost function, you can get the optimal levels. That's simply where the point of tangency occurs. So the slope of the ISA quant curve is a marginal rate of technical substitution. The slope of the ISA cost curve is a ratio of the input prices. When those two things are equal, we get equilibrium. You may have seen this in other courses, but obviously this can happen in two ways. Something called a dual problem. So you can either think about minimizing cost subject to producing a fixed amount of output on the left hand side, or you can think about maximizing output given a fixed cost constraint. Now there are examples of both of these in the healthcare system. So for example, hospitals are told they have to produce 100 appointments. You do that however you want. You can spend as much or as little as you want, but you must produce 100 appointments. And the government at the moment are doing this. To clear waiting lists, hospitals are told they have to offer so many appointments a month. It's up to them how much they spend on doing that. So essentially they want to be in the right hand side. They want to minimize the costs subject to being at this point, Q1 here. Or, historically, hospitals have been told, here's your budget, fixed at the beginning of each period, up to you how many procedures you produce, which is on the left hand side. And obviously in equilibrium these both come out as the same thing, but the way you frame the problem depends on the constraints that the hospitals operate in at a given point in time. So just as I said at the beginning, it's about 10 to, but I think we're just going to carry on now and finish about 1:15 if that's okay with everyone. Because it's relatively short, there's a lot of reading at the end, that's probably better for you to do elsewhere. So probably about another 20 minutes or so. But this duality problem is sort of very common in supply, in consumer, in production theory, but it's very much applicable in the healthcare system. And again, you always get this relationship that equilibrium happens when the two curves are constant. Equal to each other. Now the cost functions are quite interesting because they allow us to look at various different properties. So total cost is essentially the sum of the prices times input. But we can also look at average cost and marginal cost. So the average cost is essentially the total cost divided through by the number of outputs you produce. And the marginal cost is the partial derivative of the cost function with respect to output. Now, as I'll come on to in the next slide, these are very different economic concepts, but people, particularly policymakers, particularly people in the media and the news, use these two terms interchangeably. If you do use them interchangeably, you get horribly wrong predictions about what happens to healthcare finances when you look at different mixes of patient characteristics. So it's a very simple economic point, but people in the media particularly, but also in politics, get these quite wrong quite often. So as I've said, the difference between average cost and marginal cost is really important when we think about health. So it's very easy to observe data on average cost. So hospitals are required to publish their cost data, so we know exactly how much hospitals spend on producing stuff, and you can count how many things they produce. So using public available data, you can get average cost for every hospital in the country. People do that, journalists do that, they ring up all the time and say they've done this amazing statistical stuff, can we comment on it? And you have to tell them politely that they've got it quite wrong, but they think they've uncovered this big story about how hospitals are operating not quite as they should be. Because if we think about this from an economics point of view, we're interested in the marginal cost. What happens when things change by one? And if we use average cost as a proxy for marginal cost, we're going to get it very, very wrong. So for example, let's just think of a scheme that is happening now. So the long-term plan, the government's missions for the NHS are to shift people away from hospitals into the community, analog to digital, and from curing to prevention. So that's three very big missions, but one of them exactly is on this. So it's moving people out of hospitals into the community so that they get better quality of care, but also reduces pressure on secondary care and reduces costs to hospitals. But if you assess that policy use an average cost, you're just going to get it really badly wrong. Because if you think about it, the people who are more likely to be moved out of hospital into the community are the people who are relatively more healthy. You have a lower cost anywhere. So the average cost is probably going to change quite a lot. But the marginal cost isn't changing by anywhere near as much. So you can say it's a very effective or very ineffective policy based on your underlying hypothesis, but actually you're not getting at what you think you're getting at. Because you're moving a group of very or relatively more healthy people with lower costs out of hospital. So the hospital's total cost probably won't change that much. The average cost might change because you've got a lower denominator. But if you did that using marginal cost, you're going to get a very different approximation. So we know that the marginal cost is always lower than the average cost. And it can be substantially lower than the average cost. And again, when we think about multi-product firms, the average cost is essentially meaningless. However, the marginal cost does exist and it is well defined, and you can calculate the marginal cost for each of the outputs in the multi-product firm, if we assume ceteris paribus. So you've probably seen all of this before. Total cost curves are typically some sort of weird inverse S shape, where it starts off concave and then gets convex. And the point at which it switches from concavity to convexity is essentially where the marginal cost curve cuts through the average cost. So you can see here at low levels of operation, like we said before, the marginal cost is always lower than the average cost. When you get this rapidly increasing change such that total cost increases quite steeply, marginal cost races above average cost at an almost exponential rate. So again, depending on the initial amount of operations procedures you're doing in hospitals is going to really influence whether you show a policy is effective or not. So economies of scale basically piggyback onto this idea of cost. We need to differentiate between the long run and the short run. So again, the long run is when we have all inputs can vary. You can do what you want to all inputs. Whereas in the short run, at least one, but typically most inputs are fixed. So we're going to focus on the short run for simplicity, but you can generalize the long run and you get essentially very similar results. So the shape of the total cost curve essentially basically maps out economies of scale. So economies of scale tell us how total cost changes based on changes on outcome. So essentially these scale economies come directly from returns to scale, but we can relax this idea and we can look at the short term because we can allow some things to become variable. So if we have constant returns to scale, we're going to get a straight line total cost curve. It could be cost, average cost and marginal cost, essentially a constant straight line. But that's very unlikely to happen, as we've said. So economies of scale, or scale economies as it's sometimes called, essentially says that you can get a less than proportionate increase in total costs as Q changes. So if we have scale economies, then the total cost of producing twice as much output is less than twice the cost of producing that one amount of output. So if we get more output, or double output, but costs are less than double, we've got economies of scale. And again, this tends to happen at low levels of quantity, but at some point you go from economies of scale to diseconomies. And essentially that happens where the marginal cost curve intersects the average cost curve. So essentially here, given the total cost curve, up to this point here, we have economies of scale. So if we go from 20 to 40 operations, price increases from just over 40 to about 70, which is less than twice 40. But if we go from 60 to 120 operations, then cost more than doubles from about 90 to about 210. So essentially anywhere between this point of inflection, the origin and this point of inflection, we have economies of scale. Then anywhere above that point, we have diseconomies of scale. And this diagram is used by some people to show why big hospitals are better, because you've got economies of scale. But people rightly point out that's only true up to a set amount of operations. Any super hospital bigger than the point where we go from concavity to convexity, we're going to run into diseconomies of scale. And we need to work out where that number of operations is. How we do that basically allows us to say whether these super hospitals are good or not. Do they result in cost savings, or do they actually result in wasted expenditure? So economies of scope are related, and this links more back to additivity of costs. So we said earlier that a general hospital or any other multi-product firm could be more efficient if they were in one big super facility. So if you bring lots of different smaller hospitals together under one roof in one building, is that cheaper than if they were done, if this healthcare was produced in separate smaller hospitals? So if the total cost for producing things together is cheaper than the total cost for producing exactly the same amount of stuff but in separate institutions, then that's called economies of scope. So if the cost of a specialist hospital plus the cost of a specialist dentist is bigger than the cost of a centre that does both dentistry and hospital activity, then we have economies of scope by bringing the hospital and the dentist together under one roof, such that they can share things like x-ray machines, dental nurses, general nurses, etc. So scope economies come directly out of additivity, but in the cost function. So an additive cost function essentially says that the point of joint production is exactly equal to the cost of producing everything in separate facilities, so we have neither economies or diseconomies of scope. If we have sub-additivity of costs, so it's cheaper to produce things in one big shared facility, then that is economies of scope. And that is one of the main reasons, again, that people use to bring facilities together into these big, large hospitals. We could theoretically have the opposite, so it could actually be cheaper to produce things in many smaller facilities than it would be by bringing things together, in which case we have diseconomies of scope. And essentially, algebraically you can show it, but you can just take my word for it, that additivity in the cost and additivity in the production functions are always opposite. So additivity of cost, if you have subadditivity of cost, you must have superadditivity of production, and vice versa. So if you can produce more with the same amount of inputs, it must be cheaper to produce them than the alternatives. That always has to be the case. So if you have a subadditive cost function, you must have a superadditive production function, and vice versa. So economies of scale and economies of scope together are the two determinant or the two driving factors that are used by people who want to push big hospitals. And economies of scale tell us how output changes as input changes. And again, economies of scope is similar but distinct in that it's on about bringing things together or not. And again, economies of scale is quite hard to generalise to the multi-product firm, whereas economies of scope is very easy to generalise to the multiple goods that are produced in multi-product firms. So the key question is, and again there's no right or wrong answer, people have very strong opinions on this, people's opinions change all the time, but the things that we've discussed here, the very simple economic concepts we've discussed here, are exactly the tools and economic concepts that are used correctly and incorrectly by policymakers to argue that we need to invest in super hospitals. We need to close down small regional hospitals, we need to invest in super hospitals and big city centres. So most competition policy essentially says we shouldn't do that. We should have lots of smaller providers producing similar goods. The government very strictly enforces this policy, but when it comes to hospital and healthcare, it completely ignores that policy and almost does the exact opposite. So we are encouraging very big monopolies for the provision of healthcare, which basically is completely against competition policy. But people argue that the healthcare sector is so different that we need to forget about those rules. The healthcare sector wastes so much money by having inefficiencies, by having lots of smaller things doing essentially the same thing. So we need to think differently. We need to have big hospitals that are more efficient. We can produce the same for less money, or we can produce more for the same money. So it's really interesting that Basically, we think this for health, but think very differently for everything else. Essentially, a lot of this boils down to this point of, well, where is that theoretical maximum? When do diseconomies of scale take over from economies of scale? When do diseconomies of scope take over from economies of scope? Now, each of those 4 links there take you to various things. So the King's Fund is a healthcare charity in England. They did a report basically a few years ago now, when this policy really came out, when the government were actively closing down smaller hospitals and getting them to come to super hospitals. And they outlined some of the economic intuition behind that, but added some sort of notes of caution. The World Health Organization have done cross-country comparisons and compared countries where the dominant policy is big hospitals versus countries where the dominant policy is many smaller hospitals. There's something called a systematic review of academic studies, so that pulls together lots of information from lots of academic studies. And that's quite good because it allows you to get a theoretical from the data, or an empirical approximation of the theoretical maximum, of when diseconomies of scale kicks in. And they argue it's somewhere between 100 and 300 beds. Some studies find it much, much smaller. So if we do want super hospitals, we need to be careful that super doesn't become too super, such that we then lead ourselves into problems of actually we're going to suffer from diseconomies. The Telegraph did a column on this as well a few years ago when this was all political. So there's a range of ideas there. There's one sort of think tank, one international organisation with a strong interest in healthcare, some academic information and some newspaper coverage. Again, it'd be really good for you to think about this question for an exam, for example, and to think about what might be your answer if you're asked should hospitals be big, how you can link the economic concept to what we're seeing in the real world, and get some reading from beyond these 4 things here. So these are really useful, but they're by no means the definitive answers on this. And again, have a look on the internet, use ChatGPT and stuff to get ideas of what the current debate is. So this policy debate continually evolves. We don't know what the right answer is. People have very strong opinions for and against. The academic literature is a little bit mixed, but it does seem to suggest that super hospitals can only be so big. Any bigger, then you're going to run into all sorts of problems as well. So do please have a look at these 4 pieces of information, but then try and go beyond them as well. So these are really important, really interesting, but as I said, by no means definitive. So essentially we've gone through that stuff today. Next week we will have a look at how healthcare is then supplied to the market. So it's important how we produce it, but once we produce it we need to think about how we supply it. That's what we'll go through next week. And the reference is the topic 3 of the Morris book. Brilliant, I'll leave them in the section. Alright. Thank you. Cheers. you. Cheers, see you later.
Sorry, I attended like a few minutes late. I didn't get to coach for the lecture. My bad.
Sorry.
That's no worries.
I thought I had my phone, but I haven't.
I also just wanted to ask, so is the first exam, it's like an essay?
Yes, the Simon.
Yeah.
Yeah, it's a short essay.
Okay. So like the best way, like how would you suggest the best way there for that would be?
So the question will come out in a couple of weeks' time.
Okay.
Have a look at that. It's a very short answer.
Okay.
But everything you need to answer, it's been taught in the class.
Okay. So just reviewing all the.
Yeah, exactly. And feel free to get in touch. Obviously, we can't answer specific questions, but
Of course.
if you've got any.
Oh, thank you. Scan it. Okay, yeah. Thank you so
Thank you.
much.
Actually, is that not your coat? No.
Oh no, that's not mine. I'm sure someone will come back.
Yeah, thank you.
Thank you. Have a nice weekend.
You too. Take care. Bye.